Hopefully by now everyone's familiar with TrueCode and you've had an opportunity to jump on these webinars, but for anyone who's not, we make encoder technology that's used by hundreds of hospitals, consulting firms, and payers. We have a unique approach to coding that's been proven to increase coding accuracy and productivity, and we have a really flexible workflow that coders love. So we would love the opportunity to show you what we're all about, and if you're interested, you can register for a demonstration, a web demo. We offer them on a monthly basis, and you can sign up for them on our website. Before I introduce Joy, I just want to review a couple of housekeeping items. First, everyone's in listen-only mode, so if you have a question, please submit it through the Q&A section of the control panel. We most likely will not have time to answer all of the questions at the end because, as Karen said, we have a lot for Joy to go through. However, she has offered to answer your questions and we'll follow up by email. So please make sure to get those questions in, and please make sure you submit them in the Q&A section, not the chat, because it goes to different people and it's tough for us to aggregate all of the questions if they're entered through the chat. So please submit them through the Q&A section of your control panel. As I mentioned, we sent out handouts earlier. You can download those in the reminder email that was sent out about an hour ago. Finally, and most importantly, we want to make sure you receive your CEUs. So for everyone that's attending the live webinar, we'll be sending out an email tomorrow. It will contain a link to a brief evaluation. We ask that you complete that, and once you submit your response, you'll be able to download your CEU certificate. For those that are viewing this on demand at a later time, the instructions for downloading your certificate will be provided at the end of the webinar. And if you have any questions or problems, you can always send me an email by responding to your webinar email invitation. Okay, so now I would like to introduce you to today's presenter, Joy King-Ewing. Joy is past president of the Alabama Health Information Management Association, a distinguished member of the organization for 2003, and she's held several positions on the AAHIM board. She owns Joy King Consulting, and she conducts coding and CDI audits for inpatient hospitals, and she works as an independent contractor with administrative consultant services as well as TrueCode. She offers presentations on coding, clinical documentation, and other topics related to coding and healthcare reimbursement. And Joy has spoken at multiple state and national meetings on a variety of topics, and we're so grateful that she's here with us today. So Joy, I'm going to hand it over to you. Thanks so much for being here.
Thank you so much, Sharon, and it's great to be able to talk with y'all again. Today, you see the objectives on this slide, which I think are inherently obvious, so I'm not going to read those for the sake of time. So we're going to jump right into the first guideline change in the general guidelines section. Just a slight little change here. The things that are in bold are the things that were changed this year. And they've just added that word with when they're talking about etiology, manifestation, convention. An example is dementia with Parkinson's disease, which means that the code G20 is going to be coming first because it's the etiology or underlying cause. And then the FO280 or 81 are going to show the manifestation, which is the dementia with or without behavioral disturbances. Then we also have, they've been adding to this list over the last couple of years, documentation that we can code from that is from clinicians other than the physician provider. And they've added under immunization status this year, which is a new thing that they're trying to pick up and capture. And they're obviously reminding you that all of these things up here, including under immunization, should be reported as secondary diagnoses, and also referring you to the section in the guidelines regarding social determinants of health, because that is one of those kinds of factors. Then we have a guideline clarification related to complications of care, which, as you know, is tricky to code sometimes because of the documentation that you get from the physicians. And they've said down here that there has to be a cause and effect relationship between the care provided, and the documentation must support that a condition is clinically significant. Now, I've underlined a few things here just to highlight those importances, but clinically significant is kind of a new thing that they're adding. If you've been coding for a while, one of the things that they've talked about often through the years is serosal tears, which occur during certain surgeries. The tissue in that area is so fragile and friable that it can be cut or tear easily, and that isn't necessarily a complication because it's somewhat of an expected thing. So when it comes down to trying to figure out if it's clinically significant or not, it's kind of tricky. They are telling you that the physician does not have to use the word complication, but what you're looking for in the op note is whether it can change the course of the surgery in the op note, and that's going to be pretty clear from the documentation in there by the provider. So hopefully, if you can tell that it really had an impact on what they did in the surgery, you are able to pick it up as a complication code. And of course, as always, if you don't know for sure that there's a relationship between the complication and the care, you would need to query the physician. In the infectious disease chapter, didn't have a whole lot of changes. I just wanted to point out this one code split here, candidiasis of the vulva and vagina, where we now have a code for acute and chronic. We have a guideline change or two in the infectious disease arena. We have a new code that's coming out this year that we'll be talking about in a few minutes, which is hemolytic uremic syndrome, and D5931 would be assigned for an infection-associated hemolytic uremic syndrome. What they're telling you here is that unlike a lot of other conditions that are related to HIV, the B20 would be principal diagnosis. In this case, the D5931 would be principal diagnosis, and the B20 would be a secondary diagnosis. Down here, they're simply just kind of clarifying with some additional wording, HIV disease, HIV-related illness, or AIDS. All of those basically mean the same thing. Same thing with the sepsis. We have some sepsis guidelines already in place where other things besides sepsis are principal diagnosis, and this would be another one of those. If you have hemolytic uremic syndrome from that sepsis, that would be coded as principal diagnosis, and the hemolytic uremic syndrome would be listed, the sepsis, excuse me, would be listed as a secondary diagnosis. And then we have in the COVID guidelines, under immunization for COVID, again, a reference to under immunization documentation by clinicians other than patient's provider, which you already saw that guideline change in a previous slide. In the chapter 2, neoplasms don't have a whole lot of changes here. I just gave you a couple of little, note changes and things like this on this slide. But we do have a couple of guideline changes to go over. If you have a patient coming in for treatment of the primary site of the neoplasm, and it's the primary reason for admitting the patient, and that is where the treatment is directed, then obviously that is going to be the principal diagnosis or the first listed diagnosis. The exception to that, as always, would be if they're coming in to be treated with chemo, radiation therapy, then you're going to have a Z51 code as your principal diagnosis and the underlying diagnosis or the neoplasm as a secondary diagnosis. Then we do have a reference here. If the primary malignancy has already been removed, they refer you to the secondary malignant neoplasm guideline here, which is new. And we're talking about lymphoid tissue here, which is not like a solid tumor. Lymphoid tissue, as you know, is throughout the body. So it's coded differently and it's handled differently when it metastasizes. And basically what they're telling us is that when lymphoid tissue neoplasm metastasizes beyond the lymph nodes, a code from categories C81 to C85, which would be the solid organ sites that it metastasized to, would be captured with the code with a final character of 9, which indicates that it's extranodal in solid organ sites, rather than coding a secondary neoplasm of the affected solid organ. So the example here that's given is metastasis of B-cell lymphoma, which has gone to the lung, brain, and left adrenal gland. Instead of assigning secondary neoplasms for these sites, you're going to code it to C83.3, which is the diffuse large B-cell lymphoma, and the 9 will be showing you that it has moved outside to solid organ sites. Then we have here the hemolytic uremic syndrome that I was talking about in those guideline changes previously. They deleted the use additional code note that was underneath the category D59.3 and added a code also note. And then they've given us a split here. This one is for unspecified. This one is hereditary, and this one is other. And you have code also and code first notes added in a lot of these, and use additional code notes. And one of the reasons that I covered all that stuff in here also is because if you are lucky enough to have an encoder that shows you all these notes in the tabular, like the encoder that I use, which is TrueCode, does, it gives you a leg up because these things have a lot to do with sequencing of diagnoses. Code first is a sequencing direction. Code also can be a sequencing direction. Using additional code can be a sequencing direction. So it's important that you understand what those notes are when they change. The other thing I wanted to tell you about the hemolytic uremic syndrome, again, from the Coordination and Maintenance Committee minutes, all the clinical information I'm giving you today came from minutes from the March 2021, September 2021, and March 2022 meetings. This syndrome usually occurs after a GI infection, often caused by E. coli, although sometimes it can be linked to non-GI infections, especially if they have an infection caused by pneumococcus. But that's what that syndrome is. And again, a reminder of the 2 guideline changes that we talked about a few minutes ago. And then this excludes one under here with the coagulation defects. Remember, they're changing it to an excludes note. And just as a reminder here, this is telling you that excludes one, which says I can't code this with these complications, has been changed to 2, which now says I can code this code, but I could also add a code for one of these complications if applicable. This von Willebrand disease, I believe we got some codes about this a year or 2 in past, but now they've given us an additional set of codes for the different types of von Willebrand. This is primarily an inherited bleeding disorder where the blood doesn't clot properly. That von Willebrand factor is a protein that causes the blood to clot, and if they have low levels of that, then they're not going to clot like they should. Type 1, 2, and 3 are new codes that we have, and type 2 is even split out even in further specificity. Those 3 are inherited disorders, but they have discovered a rare type that is acquired, and so they've got an additional code here for us to use for that. Primarily what they're doing in this disorder is they have 3 main medications that they use to treat it in order to control the bleeding. We also have a qualitative platelet defect because von Willebrand's does impact that. And they've, made a note here, changed this excludes 1 to excludes 2, meaning that you could code this plus this if applicable. Then we have this new set of codes for heparin-induced thrombocytopenia, or HIT. This is a decrease in the platelet count that occurs during or shortly after exposure to heparin, which, as you know, is widely used in the hospital setting to prevent or treat blood clots. And so this is a common problem that can be very serious and life-threatening to certain patients. There are 2 types that had been previously identified, type 1 and type 2, and recently they've identified a 3rd type known as an autoimmune type. So they've added this different specificity here for us. And type 1 affects about 10% of the patients, occurring within the first 48 to 72 hours after starting the heparin, and it does not increase the risk of thrombosis or other complications. However, the type 2 is an immune antibody reaction that occurs 5 to 10 days after starting the heparin. It can be associated with hypercoagulable state, and it can lead to arterial thromboses, DVT, and pulmonary emboli, which can be serious in themselves. But the other thing that this does is trigger the patient safety indicator 12, which is perioperative pulmonary embolism, or DVT, and they wanted to have a separate code to pull this type out so that those would not be counted in the numerator of the patients that fall into that patient safety indicator. So that's another reason for that additional code specificity. In the endocrine disorder area, not a lot of different changes, but we do have this new short stature additional code split here. Short stature due to endocrine disorder has been spelled out with constitutional and other, and under the constitutional we have primary insulin-like growth factor deficiency or insulin growth factor resistance, other, and unspecified. This short stature that is due to endocrine disorder is a hormonal disorder, and the most common of those is this first one here, the insulin growth factor deficiency. We also have a big change with E87.2 acidosis that I wanted to talk about. This code is used a lot on a lot of the cases that I review, especially if the patient has sepsis or sometimes acute respiratory failure, they'll develop a lot of this. And there's a new code split here. There's a code also note for respiratory failure with hypercapnia if you assign that E87.20 unspecified code. And then we were able to specify acute and chronic metabolic acidosis. In this case, they are asking you to code first the underlying etiology of the acidosis. The definitions are here on the slide. Acute would be usually associated with something that causes hospitalization, like a big infection and sepsis, etc. And they're going to be, treating with antibiotics, volume resuscitation, control of hyperglycemia, etc. Chronic is really a chronic condition primarily due to CKD. And so the main reason that they're treating that, or the main way they're treating that, is with increasing serum bicarbonate levels over time. It is a very serious complication, and it is an underlying reason for CKD progression in a patient. I also want to show you this index change just to highlight something else that's significant. As you can see, currently the index reads acidosis with lactic and respiratory in parentheses as non-essential modifiers for that E87.2 code. So lactic and respiratory have all been grouped under that code, leading up to October 1. However, what they have done is to split that out and move that down here, and they have taken respiratory from E87.2 to E87.29, and that's if it is not specified, if it's unspecified. But if it's specified as acute, they're actually now sending you to acute respiratory failure with hypercapnia. And if it's chronic respiratory acidosis, they're sending you to chronic respiratory failure with hypercapnia. So those are significant changes that I wanted to make sure you were aware of. These are the definitions of acute and acute on chronic versus chronic respiratory acidosis. I'm not going to read those for you right now. They came from uptodate.com, but they're available for you if you were having to try to make a decision about what you're looking at or needing to issue a physician query, etc. And then in the guideline area, there's always one for diabetes, seems like every single year. And in this case, we have a new code this year for coding those injectable non-insulin anti-diabetic drugs. And so they are spelling out here again, as you know, initially they told us that if the patient was on an oral hypoglycemic and insulin, you would only code the insulin. And then they changed it so that you would code both. And now they're adding this new code to make sure that that also gets captured along with other things that the patient is being treated with. I'm sure that they're interested in trying to follow the progression of the diabetes, and the more different types of drugs that are being used to control that diabetes is, a big factor in trying to figure out how far down the scale that diabetes has progressed and how well, they are keeping the patient under control. One point that I'll make about this, there is a use additional code note to show control under all the diabetes codes. And I rarely see coders coding that. I make that as an addition on a regular basis in my audits, because the use additional code note is not if you feel like it. You should be using it if you have documentation of insulin or oral hypoglycemic or whatever. You should be adding a code for that. I think it's very important data for them to capture in that diagnosis area. And they're doing the same thing with the secondary diabetes of talking about the new code and making sure that all of those things are picked up. Dementia, lots and lots of changes in the dementia area. Dementia is technically known as major neurocognitive disorder, and it's characterized by a significant decline in cognitive function, such as memory, problem solving, attention, language skills, etc. And it's usually due to an underlying cause like some type of cerebrovascular disease or Alzheimer's. They are obviously often not able to treat the underlying conditions. So what they're having to treat is the behavioral disturbances. And those are the things that often define what type of care that patient receives going forward. We haven't had a lot of specificity in the code selections. We mostly could show with or without behavioral disturbances, but not really characterize what those were. And so they have added a lot of new codes in all the dementia areas for spelling out the behavioral disturbances. And you can see here, this is the example for vascular dementia unspecified. The first one is 401 or FO1.50, unspecified severity without behavioral disturbances. And they go on and kind of spell out what those would be. And then they move on into the specific behavioral disturbances and spell those out. Agitation is considered to be the most disruptive of all of them, primarily because it seems to be the one most likely to determine if the patient's going to have to be institutionalized or not. But you can see we have agitation, other disturbances, psychotic, mood disturbance, and anxiety. And basically what they have done is to give us a breakdown for those behavioral disturbances, and they have given us a whole new set of codes to show the severity level of the dementia. So this is an example of the vascular dementia mild severity new codes. And again, we have, without behavioral disturbances and then ones with all the different types of behavioral disturbances. So they have worked their way through all the types of dementia and given us the severity level breakdown as well as the types of behavioral disturbances for all of those. Also, this mild neurocognitive disorder unspecified has been coding to G31.84. But when it's due to a known physiological condition, they have given us a new code starting October 1, this FO6 category with and without behavioral disturbances. And the reason for that is because they're finding that there are a lot of other underlying causes besides just Alzheimer's that are causing dementia and impairments. And they want to be able to capture those different types of conditions and track them and figure out how to treat them. So that's the reason for this additional change right here. We also have a personality change code here, and the one I wanted in particular to talk about here is this one. They've given us a code split for alcohol use unspecified, uncomplicated, and in remission. And then they've given us that same breakdown for codes with all of these different substances on the slide here. And then they have some stress reaction codes here. This one has been split out for prolonged grief disorder and then other reactions to severe stress. Now, referring back to those alcohol codes that I was just talking about, they've added a guideline change here. Again, the underlining part is my emphasis. If you have codes for in remission, which we now have in these categories, selection of codes describing in remission for categories F10 through F19 require the provider's clinical judgment rather, and are assigned only on the basis of provider documentation. I wanted to specifically highlight that again because I see frequently in audits where coders are assigning an in remission code where I see documentation that maybe the patient stopped using that substance a month or two ago or whatever, stopped drinking a month or two ago, but I see no documentation clinically by the physician to say that that patient is in remission. So I want to highlight this to make you aware of the fact that you cannot code that in remission code without clear documentation from the physician that that is the place that that patient is in. And if you're not sure and you think that they might be in remission, but he hasn't specified that, then you would need to issue a query for that. And here is another guideline related to dementia because of all the additional codes that they have given us on the severity levels, stating that the selection of the severity level requires provider's clinical judgment. Codes should only be assigned on the basis of provider documentation. It's not up to us to decide whether it's mild, moderate, or severe dementia unless the provider makes that clear. And it says if the documentation does not provide information about the severity level, assign an unspecified severity code. Now, if you have some documentation in there that makes you think it might be, moderate or severe, but he hasn't actually told you that, then I would issue a query. But otherwise, you're going to need to code it to unspecified without that specificity. The other part of the guideline here is that if they come in to an inpatient setting with one severity level and progress to a higher level during that stay, they're going to assign only one code for the highest level reached during that stay. This is like a lot of other conditions that they have given us this same guidance, but it is different from the way we handle pressure ulcer staging, as you know. Then we have some different little changes related to different diagnoses in the nervous system that I'm not really going to spend much time going over here, but you can take a look at those. A lot of muscular dystrophy codes added, 10 new codes added for limb girdle muscular dystrophy. I'm not familiar with this. I rarely ever even see this diagnosis, but just wanted you to be aware of all of those new codes that have been added. We also have a new code for a new condition called POTS, postural orthostatic tachycardia syndrome. And there's a lot of explanatory phrases underneath there about, what is going on with that, what it means, et cetera, like other wording that you might see on the chart. But what it is sign of tachycardia that's noted on a patient standing, and it even either returns to normal sinus rhythm or persistent sinus tachycardia, but at a slower rate when the patient assumes a recumbent position. It's usually triggered by infectious agents. However, this is can become a chronic nervous system disorder that can cause a lot of disability and impair the quality of life of patients. And so they wanted to have a separate code to capture this and track this and, track how they're treating it and how patients are doing. Then we also have some new codes for post-viral and related fatigue syndromes. Primarily what we've had in the past is to code everything to chronic fatigue syndrome, which is kind of a catch-all code. And it doesn't give us a lot of help. And one condition in particular that they're interested in tracking is this myalgic encephalomyelitis / chronic fatigue syndrome, ME/CFS, because it is very complex multisystem disease that can be very debilitating. 25% of the patients that have this are homebound or bedbound, and 75% of them either are unable to go to work or go to school. So it's a very serious chronic condition that they want to be able to capture, hence the new split with the different codes. In the circulatory system, we have some changes. We have a bunch of new codes for refractory angina pectoris, and just to remind you what that means, it's not responding to treatment, very difficult to treat and control. So they've split out or added a new code with refractory angina for all of these different categories that I have listed on the slide for you. Then we have a new code for pericardial effusion, and they've split it out between malignant pericardial effusion and other. This is something I did not know, but about 10% of cancer patients develop cardiac metastasis. And of those, 3/4 of those will have metastasis to the pericardium. And so about a third of those are going to develop a malignant pericardial effusion. And if you have a cancer patient that develops symptomatic pericardial effusion, apparently that is suggests a very poor prognosis for that patient. So they wanted to be able to track those. There is a code first note here, obviously telling you that you would code first the underlying neoplasm and then add this in as an additional code. And then we have some extra specificity for non-rheumatic mitral valve annulus calcification and other mitral valve disorders. Some split in the I-47-2 VTAC codes, unspecified and other VTAC we have, but the one in the middle, torsade de pointe, it's a condition that can be significant. If left untreated, sometimes it can resolve without treatment, but if left untreated, it can cause the patient to develop VFib, and that can lead to cardiac arrest. So they want to make sure that they can, track that and separate it out from these other VTAC cases. There is a code including third quarter 21 talking about this condition as well that you might want to take a look at. And then we have a lot of new codes related to aneurysms. There were 22 new codes. The first one on this slide is showing dissection of the thoracic aorta, and they have given us additional code splits to show the different parts of the thoracic aorta, the ascending, aortic arch, descending, and unspecified. And this is for the dissection, and they have the same breakdown of parts for the actual aortic aneurysm. And they've done the same thing for abdominal aneurysms, with and without rupture, and thoracoabdominal aneurysms with and without rupture. So just be aware of those additional choices that we have with a lot more specificity than we've had in the past. Another index change, this is just a correction that should have been done a long time ago. If you were coding a complication like, let's say, a hemorrhage related to a cabbage graft, the index has been sending you to complications of vascular devices and grafts instead of sending you to complication of cardiac devices and grafts, which is where it should go. So they have re-indexed all of that to make sure that you are sent to the correct place of cardiac devices and grafts if it's a complication of a cabbage. In the respiratory system, not a lot of changes, a couple of code first notes here, but we do have one new diagnosis code that they've given us for transfusion-associated dyspnea, or TAD. It will be a CC, and the excludes one underneath there says it's different from taco and trolley. We've had taco out for a while, and I'm not really sure when trolley came out, but they requested a separate code for this condition because they're finding in the data that this can be a pretty serious transfusion-related pulmonary complication. And as they're looking, they're seeing that red blood cells, platelets, plasma transfusions, and in particular, COVID-19 convalescent plasma transfusions are causing this. So they want to have this separate code to be able to track all of that. Here's the definition by the CDC about transfusion-associated dyspnea: acute respiratory distress occurring within 24 hours of cessation of transfusion and allergic reaction, and where taco and the trolley definitions do not apply. And on this slide, you'll see their definitions of taco and trolley. I'm not going to read those for you, but they're there for you so that you make sure you understand the distinctions between those two conditions, as well as the new TAD that we have a code for October 1. In the digestive system, not a lot of changes, but they've added and gangrene to the wording of these two codes that did not have that in the past. So that's helpful. But we have this new code for hepatic encephalopathy, which is great. However, unfortunately, and I'm not really sure I understand why, it is not a CC or an MCC, which it should be as far as I'm concerned. But they've added, along with the code, this code also the underlying disease note. And so I want to specifically tell you that because often the underlying cause of the hepatic encephalopathy is going to be an MCC or a CC. So even if you don't get credit for this code here, you hopefully can get credit for the underlying cause being a CC or an MCC. Basically, it involves altered mental status and behavior related to insufficient liver function when the liver is unable to remove toxins from the blood, like ammonia, and the ammonia levels are the things I see the most on the chart. It will cause brain dysfunction and sometimes leading into up to a coma. A lot of discussion in about 3 years worth of the C&M committee minutes about this issue, and they were talking about a grading system for hepatic encephalopathy. The primary one being West Haven grading system, where there were 4 stages of this, 4th stage being coma. However, they did not decide to include those in the changes that are going into effect October 1. You might want to be looking for that going forward to see if they end up incorporating that in future changes. We have a new set of codes for lumbar and lumbosacral annulus fibrosis disc defects. And you can see the breakdown here depending on the size of the defect and the part of the spine that it's talking about. There's a code first note under these that ask for you to code the lumbar disc herniation itself. And then we have some new codes for muscle wasting and atrophy of the back, different parts of the back. We've had codes for slipped upper femoral epiphysis before. We had right and left hip, but not bilateral hips. So they've added codes for bilateral hips throughout this code breakdown. They've also added separate code breakdowns for stable and unstable within these pre-existing code sets that we already had. So be aware of those additional code breakdowns that are capturing that additional specificity of the hips and also the stability versus non-stability. This one is a really important one right here. They have been long asking for codes to separately capture fractures that occur with chest compression or CPR. There was a coding clinic that came out in first quarter 21 that said coders should code M96.89, other intraoperative and post-procedural complications of musculoskeletal system for rib fractures due to CPR. And that's consistent with previous guidance to tell coders not to assign traumatic fracture codes for these when they occur due to medical intervention. However, they're finding in the data that many coders are assigning traumatic fracture codes to these fractures that occur in the course of medical care. So they don't want that to happen. And so they have given us a whole separate split of codes here. The first one is sternum associated with compression and CPR, one rib, multiple ribs, other, and then the flail chest is separated out in addition to that. Another issue that they're concerned about related to this set of new codes, AHRQ is the one that asks for these codes because this also triggers patient safety indicator number 6, iatrogenic pneumothorax, and they don't want those cases, which are an expected complication of CPR or chest compression, to be counted in the numerator for those cause cases in that PCI, patient safety indicator. The definitions of flail chest, there are two down here on the slide. One is from the Mayo Clinic, 2 or more contiguous rib fractures with 2 or more breaks per rib. And then the one for the NIH is 3 or more ribs broken in 2 or more places. They note here that this is a clinical diagnosis because sometimes patients will have this fracture pattern, but they will not develop flail chest. What happens with flail chest is the fractures cause a segment of the chest wall to move independently from the rest of the chest wall, which sounds awful. The flail chest code is going to be an MCC, but the other fracture codes listed here will be CCs. Then we have some changes in the GU system. New code breakdown for nephropathy due to drugs, medicaments, and biological substances, and they've separated that out from contrast-induced versus other. Apparently, there's about a 2% incidence from contrast dye in people that have healthy kidneys, but it moves up to 30 to 40% in patients who have CKD or hypertension, etc. And it moves from 20 to 50% if the patient has diabetes and CKD. It's the third leading cause of hospital-acquired AKI. So they want to make sure that they can specify and capture and track specifically contrast nephropathy and how often it is occurring. The definition by the American Journal of Rentgenography says acute renal failure occurring within 48 hours of exposure to intravascular radiographic contrast that is not attributable to other causes. There's also a coding clinic reference in third quarter 21 about this condition. Of course, they recommended that you code the AKI and the N14.1. October 1, of course, you would need to change that to N14.11. In addition to that, however, they recommended that an adverse effect code also be coded, an adverse effect of diagnostic agents T50 code. So I wanted to point that out as well because I see a lot of cases where coders are forgetting to code those adverse effect codes. So it's important that that would be an additional code that you would assign in this contrast-induced nephropathy situation. Then we have 135 new endometriosis codes, which is staggering to me that we would need that many. But you can see on this slide, one of the things that they've added is specificity about the depth of endometriosis, superficial or deep. And then, of course, specificity about where it occurred. Just to remind you, endometriosis is tissue that is typical to the tissue in the uterus that grows outside of the uterus. It usually involves the ovaries, fallopian tubes, and the pelvis area, but it sometimes can move to other places. But here you see the new codes that show, specificity, laterality, and depth, unspecified, superficial, and deep. Superficial is defined as tissue that extends 5 millimeters or less below the peritoneal surface. Deep would be it extends greater than 5 millimeters below peritoneal surface. Those are usually associated with deep fibrosis and adhesions. And then we have a new code for isthmocele. That is a dehiscence at the incision site of a previous C-section. It's also known as a C-section scar, C-section defect, or niche. We already have a code for that in the OB chapter, but it occurs very frequently, and there was no way to capture that in non-pregnant patients, GYN patients. And so they have added this additional code that can be assigned to capture patients that have it that are not pregnant, because it can cause pain, abnormal bleeding, secondary infertility, etc. Then we have several codes in the maternal area, pregnancy area, or maternal care for central nervous system malformation of the fetus. We have a new set for chromosomal abnormalities in the fetus, and then another set for fetal abnormality or damage, fetal facial abnormality anomalies in the fetus. And then a couple of guideline changes in the OB area. They're clarifying that completed weeks of gestation, which we have to have a code for that, means full weeks. So if they say the patient had gestation at 39 weeks and 6 days, that is not 40 weeks, because it should be 7 days. So it's 39 weeks at that particular case. You're not going to round up, you're going to round down when it comes to weeks of gestation. And then they've added in the gestational diabetes guideline that same thing for the new code for the the injectable non-insulin anti-diabetic drugs. Then they have a new guideline related to hemorrhage of following elective abortion. They tell us to assign O04.6, delayed or excessive hemorrhage following termination of pregnancy. And I've underlined here what we are not supposed to assign. Do not assign 072.1, because it is not an immediate postpartum hemorrhage when it's a post-abortion condition, and do not assign a Z code for encounter for an abortion. Make sure you are aware of that new code and assign that code instead. In the perinatal period, we have a lot of new codes related to sleep apnea. Apnea is defined as cessation of breathing for 20 seconds or longer, or shorter pauses along with bradycardia that's defined as less than 100 beats per minute. Cyanosis and pallor. Central apnea is caused by immature medullary respiratory control centers, and it's most common the type of apnea that premature babies would have. Obstructive apnea is caused by obstructed airflow, neck flexion, nasal occlusion, or reflex laryngospasm, and mixed would be a combination of those two types. Apnea of prematurity is one of the most common diagnoses for patients that are in the NICU. But that is different from the sleep apnea that we're talking about on this slide and these new codes. This is based on polysomnography that they do on the baby because of indications that they have, and they typically will send those babies home on a monitor to detect apnea and bradycardia. And then we have a split atrial septal defect is considered a major malformation, whereas patent foramen ovale, which you see pretty regularly, is not considered a particularly serious complication. It's found often in a normal newborn in the immediate period, and it doesn't become a big issue. But these do. So they have separated out the types of atrial septal defects, etc., to capture all that information and allow researchers to have a better idea about how these defects affect the babies and how they can improve patient care. Again, some new codes for atrioventricular septal defect as well. And then some new codes for other phacomatoses. In the injury chapter, the primary change that we have here is related to loss of consciousness. We have 86 new codes related to loss of consciousness. Currently, the three choices that we have to choose from are without loss of consciousness, with loss of consciousness of 30 minutes or less, and with loss of consciousness of unspecified duration. And that implies, the last one implies that there was a loss of consciousness, maybe, and nobody knows. So they've added a fourth option throughout all these different code categories, stating, and then it's ending with an A, stating with loss of consciousness status unknown, meaning the doctor has not documented anything about the issue. So in all these categories, the new A code will become the default code rather than the unspecified code that we've been using. That will become the default code if there's no documentation of loss of consciousness on the chart. Then we have a set of injury codes related to primary blast injury of the brain. Again, a breakdown with all kinds of things about the loss of consciousness time frame and, whether they recover, whether they don't, etc. And again, you see that A breakdown that we have down here as well, related to with loss of consciousness status unknown. We have a new set of poisoning codes for poisoning, adverse effect, and underdosing of methamphetamines. And then we have an additional clarification about the underdosing code. And I'll just state right here as well, I frequently see this getting missed by coders also. It talks about, that when the patient is taking less of a medication than prescribed, or discontinuing it, those are considered underdosing. And it also talks about how, if they're taking medicine for CHF, for example, and they aren't taking it, their CHF could exacerbate, and you might need to, pick up that as well. But I frequently see documentation in the chart that the patient has quit taking their medicine altogether, or they're not taking enough, and underdosing should be coded in those cases. It says right here that a documentation in the change of the patient's condition is not necessary in order to assign that code. As long as there is documentation that the patient took less or quit taking it, an underdosing code is warranted. And then in the external cause codes, we have a big old ton of new codes as well. And basically, to summarize all of them, they are trying to differentiate the type of bicycle. But electric bicycles are becoming more and more common. They move at a higher rate of speed than a regular bicycle. Obviously, they can go up to 20 miles an hour, and they want to be able to capture injuries related to that. So they've added separate codes so that we have bicycle, electric bicycle, or other motorcycle. And then they've also added a lot of specificity about the driver and passenger. Who was the driver and who was the passenger of each of these types of vehicles. And that's a basic summarization of all those changes in the external cause codes. Lots of new Z codes. We've got 3 right here that are social determinants of health that have been added this year. And we have a lot of codes. We have, let's see, 15 new codes for long-term effect of different drugs. And one thing that you'll notice here, they've got explanatory phrases under some of them. I didn't add them all, but just to give you an example, that will tell you, what type, like the names of the drugs. But you can see here that they're trying to capture what those drugs actually do. So they're not trying to capture, the reason they're being given the drug, but what is the drug actually, how does it work on the body? What is it actually doing for the patient? And that's what these different categories are that have been added. And as I said, you're going to find explanatory phrases like this one here is one that one of my family members has started having to take the last 2 years. And the drug that's primarily used in that area is hydrourea, and they will have that listed in those explanatory phrases to help you figure out what types of drugs you're looking for. And here is where you also see that new long-term use of the injectable non-insulin drugs that we've been talking about throughout this presentation. We also have some other, history and deformatives. A lot of these are related to things that got corrected surgically when the baby was born or was a child. The reason they want to expand these categories is because they're finding that even though these congenital malformations have been corrected, they still often end up having sequela or have to continue to come back for additional treatment or surgical procedures, and they want to be able to capture that patient's course of hospitalizations and additional treatment throughout their lifetime if whenever possible. And then we have a whole new set of codes for patient noncompliance with dietary regimen or treatment and caregiver noncompliance with the patient's dietary regimen or treatment. So make sure you acquaint yourselves with all of those codes. Couple of guideline issues. Here we're talking about that Z codes indicate a reason for an encounter or provide additional information about a patient encounter. It's kind of a title change. And it says Z codes are not procedure codes. A corresponding procedure code must accompany a Z code to describe any procedure that was performed. And then we have a new guideline for counseling here that talks about if you have pediatric to adult transition counseling, you should code that a code if that's the sole reason for the encounter. But if they also do the counseling and treat a chronic condition, both of those should be coded, and the encounter itself should help you determine which of those would be sequenced as the principal diagnosis. And then the note here about miscellaneous Z codes, this one Z73, problems related to life management difficulty. They've added a note to clarify that these codes should only be assigned if there's a documentation about a life management difficulty that's having to be dealt with. Otherwise, there's no reason to, code that. Same thing with social determinants of health. Assign as many as are necessary to describe all the problems or risk factors. They should be assigned only when the documentation specifies that the patient has an associated problem or risk factor. For example, not everybody living alone would be assigned a code Z60.2 because if there's no documentation that they're having a problem with living alone, then there's no reason to code that code. The other thing I wanted to point out about this particular category, however, is that CMS wants us to code all the social determinant of health things that we can code, and I understand why they want that to happen. But we only have 25 codes that go on an electronic claim to CMS, and when you're trying to capture all the MCCs and CCs, and in addition, you're trying to capture all the HCCs that can impact risk adjustment for a wide variety of issues and the value-based purchasing issues and all that. And then you have all these social determinants of health codes. It's very hard to determine, what codes need to go in that 25 slots. There has been some conversation with CMS about expanding the number of slots on the electronic code, or claim rather. I don't know whether they'll do that or not, but just be aware of the fact that there's a lot that has to be considered when you're trying to figure out what you're going to fill up 25 slots with. Because let me tell you, on a complex inpatient patient, you could fill up 50 or 60 slots in a heartbeat. Now I want to switch gears and talk about the PCS changes for fiscal year 23. And hold on one second here. We have a new procedure, a guideline for detachment procedures of extremities, where they've sort of spelled it out more fully than we have in the past. It talks about the root operation detachment contains qualifiers that are used to specify where the extremity was amputated, that are based on the body part value in the upper or lower extremities. And it's coded to the body part value that describes the site of the detachment. And it gives you an example here of an amputation at the proximal portion of the shaft of the tibia and fibula would be coded the lower leg body part, lower extremities, anatomical region, lower extremities with a qualifier high. And they've added those definitions and a chart to the guidelines, which is shown here. These actually have been in existence since the beginning of PCS, and they've been housed in the PCS reference manual, but they've decided to actually incorporate this into the guideline itself. And it does give you the qualifiers, the definitions of high, mid, and low, etc. And if you see when you're talking about the hand and foot, you have to get into complete and partial. And I have here for you the definitions of complete and partial amputations. So be aware of that, these definitions that are now incorporated into that guideline. They also have revised this guideline that we've had for a while about tubular body parts. And now they're saying if a singular vascular procedure is performed on a continuous section of an arterial or venous body part, just to clarify that we're talking about, veins and arteries, you would code it to the most corresponding, the part value corresponding to the anatomically most proximal or closest to the heart portion of that arterial or venous body part. This example here is exactly the same as what they had in the last year's guideline. And then here, another little wording change related to complications, related to devices, saying if you have a device that was intended to remain after the procedure was completed and has to be removed before the end of the episode in which it was inserted, for example, the device size is inadequate, and they've crossed out or an event documented as, so it would read, for example, the device size is inadequate or a complication occurs, both the insertion and removal of the device should be coded. And I think the reason they're clarifying that is because it is pretty obvious when you end up having to, like the device doesn't fit and you have to take that out and put in a new one. It's just by virtue of what the doctor documents as he's doing all of that, it's very obvious that there was a complication that caused that to occur. So you don't really have to have it documented as a, quote, complication. Now, it's very difficult to figure out the best way to present new PCS codes, much more complicated than with the CM codes because you have 7 characters in each code that, may or may not change. So I tried to do the best I could to kind of put this in table form for you. I'm certainly not going to read through all of these things right here, but just to tell you what I've got here. The table, the first 3 digits of the table are listed over here, and I've given you what table it is and a description of the body part or area that's affected. And then I've told you what body part or what approach or what substance or whatever has changed on that table. Now, what you have to do as you look through these, obviously you're going to want to look through the ones that you think might most affect you. I've also given you here what is the procedure that warranted them changing this. Like in this case here, they're adding that cerebellum body part so that they can capture cerebellum tumor extraction using a cavitron ultrasonic surgical aspiration. And here they're trying to, code introduction of a bone substitute material. So I've tried to tell you the reason for these changes. This one down here, for example, the occlusion of the lower arteries, they've added a qualifier V for prostatic artery right and W for prostatic artery left for when you're in the body part at external iliac or internal iliac artery. And these are procedures that are done where they embolize the prostatic artery in treating BPH. So one of the things that I wanted to try to point out here about these tables, and again, why I'm so thankful for the fact that TrueCode has PCS in table format, it's very, very easy for you to see in that table format when you pick a different body part or a different approach, you get different devices, you get different qualifiers, you get different substances presented to you to choose from. And those can have a huge impact on the code that you assign and whether it's an OR or a non-OR procedure. So when you're looking at these code categories that I have listed here, make note of the specific approaches and body parts that they're talking about in these. On this next slide, you'll see this a little bit more clearly. Let's see. Well, maybe not. Maybe it's another slide I'm thinking of, but let me go back and see. I'll get to it in a minute. But at any rate, it's really important that I see a lot of errors in PCS coding where either they pick the wrong body part, they pick the wrong approach, or something. And then often, if they don't get the right body part or approach, they don't get the right device either. So pay close attention to those. And especially if your procedure code is an OR procedure, make absolutely sure that it's right, because if it's not, and they come back and deny that, then it's going to drop your DRG payment. So moving through the rest of these, the one thing I wanted to talk about in particular was this LITT laser interstitial thermal therapy. These up to now have been included in the radiation therapy tables, and you see down here, those are being taken out of the radiation therapy tables because this is thermal therapy rather than actual radiation therapy, and they're being added into these destruction tables because it is an ablation procedure using heat or thermal therapy. And they've added new qualifier, laser interstitial thermal therapy, or LITT, in all these different tables. This one is the central nervous system and cranial nerves, but they've also done it in respiratory, GI, hepatobiliary, endocrine, etc. So you need to be aware of all those different areas where that might be available to you if that's something that's being done in your facility. I failed to talk about this on the previous slide here, so let me go back to that. This supersaturated oxygen qualifier that's added into the cardiac system for continuous is important, and I wanted to talk to you about what that is. It's used to treat STEMIs, ST elevation MIs, and it involves an infusion of the patient's blood that carries supersaturated oxygen to the left main coronary artery after they've had a PCI with a stent that was completed within 6 hours after onset of the STEMI or the AMI. And the purpose of that oxygen is to reduce the infarction size after the stenting. It perfuses that myocardial tissue and endothelial tissue with that oxygen to cut down on swelling and restore blood flow. So it minimizes the damage to that area of the myocardial muscle and causes less death of tissue, so to speak. Also, talking about the LITT therapy, as I told you, it's thermal therapy done through a burr hole where they take a laser probe, and the two most often ones that you're using right now are Visualase and Neuroblate. They're minimally invasive robotic thermography tools where they use an MRI to guide them in ablating that tumor. And these are not all going to be OR procedures, but they are all going to impact the DRG assignment. This new process, however, allows the surgeon more precise control and enables maximal tumor reduction without having to actually do an open neurosurgical procedure. The last new codes are listed here. This is the one that I wanted to talk about that I was trying to think of a minute ago. In the replacement area, 020, this is talking about aortic valve replacements. And we have two changes in this 02R table here. This first one, these codes were originally came out in 2017, fiscal year 17, as new technology codes in group 3, and they have moved them into the PCS system itself. So they've done away with the X codes, and now they're adding actual PCS codes for this. If you're doing a rapid deployment technique of that aortic valve, they're adding a qualifier in this table. When it's an open or a percutaneous endoscopic approach, and when it involves zooplastic tissue. And the one that most commonly is being used is called Intuity. But that's the one that came out originally. But they also have another one now called LevaNova Percival. Notice that the same thing is happening here, except we have different qualifiers and different approach and different tissue. They're adding qualifier H, transapical, when they're doing aortic valve replacement percutaneously with autologous tissue or non-autologous tissue. And they're adding both H and N for rapid deployment for the aortic valve for the percutaneous combination of percutaneous approach and zooplastic tissue. Again, examples of how different approaches and body parts give you different devices and substances. Now I want to talk about the new technology codes, and I'm not going to go into a lot of detail here. There's a whole lot of new codes that got added to the XWO table, which is the introduction table. Over here, what I have done is add for you the ones that have new technology add-on payment, because those are the ones in particular that you need to be aware of as a coder. I also have listed in under the substance what these are used to treat, so you can look through that for yourself and see why they're, adding these new drugs. They're very, very, very expensive most of the time, and the add-on payment does not cover the cost of the drug, so you definitely don't need to miss it. And what it requires is that this X code be on the claim in order to get that add-on payment. I've seen a lot of errors in the last year and a half coding COVID patients where one of the drugs that they use in addition to remdesivir had an add-on payment. A lot of coders were missing that, even though the doctor documented it in the progress notes that they were giving them that drug, because I don't know if all coders are aware of this. The point is that you need to be, somebody in your facility needs to be looking at these new technology drugs and devices also to see whether, y'all are having those in your, does your pharmacy carry these drugs? Do they have doctors that are ordering this stuff? If they do, you need to have some kind of flag set up in the EMR to flag this, that a code needs to be assigned to the claim, a new technology code to the claim, and make sure that you don't miss out on these payments. So on this slide, the only two that are getting that additional one are the first one and this last one down here. And you can see that this one is quite a significant one. 3 different codes here for depending on, what body part and what area it is. This is a drug that's come out to treat CMV infections in transplant patients, which is a very common infection that they have. Moving on into this one, again, you have the ones that have the new technology payment. This one is an interesting one where they're adding a vagus nerve body part in a percutaneous approach, and a substance of neurostimulator lead with a paired simulation system called the Vivastim. These are being used to treat patients that have had an ischemic stroke. And when they send them to rehab, these things are used to help them improve motor function and, help them have less deficits, especially if they have upper arm impairments. So these are important. And this one right here is to prevent catheter-based infections in hemodialysis catheters. You can see here that it's still pending FDA approval, which should come out in July of 23. But nevertheless, I've got the codes out here and the amounts for each of those. And then on this table, again, all the ones that have an R new in red are new tables that were created this year. We have several of those. This one right here is to capture histotripsy of the liver tissue, which I'm going to talk about in a minute. This one here is kind of an interesting thing, coronary artery flow. And these drugs here are, some things that you need to be aware of. All of these are going to show that they're in new technology group 8 because they're coming out for fiscal year 23. But this last one down here also has a new table for this sphenopalatine ganglion, a neurostimulator lead in the insertion table. This is another device that's being used. It's another stimulator to treat patients with ischemic stroke who are not eligible for TPA or thrombectomy. And it's intended to increase the cerebral blood flow and reduce the disability in these patients, where they apply electrical stimulation to help reduce, again, the size of the infarct so that they will have better functional outcomes. So take a look at all of these things and see if there are any of these technologies that you might be seeing in your facility. Talking about the histotripsy of the liver, hepatocellular carcinoma is one of the most common primary liver cancers, makes up to 70-90% of liver cases. And liver is the second only to the lymph nodes, is the most common site of metastasis. Usually if they have tumors in the liver, there are multiple tumors, so it's very difficult to surgically resect them, and they are often chemo resistant, so very hard to treat. This histotripsy is an automated external beam therapy that destroys targeted tissue without incisions or without using ionizing radiation. Gives the physician precise targeting of acoustic cavitation using an image-guided device. Histosonics is the system that is being used in a clinical trial where they use high-amplitude microsecond pulses of the focused ultrasound directed at that tissue target. It causes a negative pressure bubble cloud of gas microbubbles that cause mechanical disruption of the tumor cells, which I think is kind of interesting. And then the other add-on payments, these are not new codes for new technology group 8. Most of them came out in 2017, or not 2017, in last year's group 7, but they are just now being approved for new technology add-on payments. This one here, as you can see, is extremely expensive add-on payment. And as I said, it doesn't even begin to cover the cost of the actual drug. So if your facility is giving this drug, you do not want to miss getting those codes on the claim for that drug. The last two down here that I wanted to talk about, you may remember discussion about this Gortag endoprosthesis that came out a few years ago that they used to treat these thoracic and aorta, or thoracic aorta aneurysms, I'm sorry. And it has two codes that are required because these endoprostheses have different branches off of them to cover all of the different parts of the thoracic aorta that they want to cover. So it usually requires those two codes on the bill to get the full payment. Same thing with this one right here for the same reason. So again, set up a way to follow these and make sure that somebody is paying attention to this and putting flags in somewhere so that the coders can be notified that these X codes need to be added on the claim. Another point that I want to make before I move on to the last section, there are 15 different new technology payments carried over from last year that are continuing to give new technology payments for this year. I'm not covering these today for lack of time, but hopefully somebody in your facility already knows about them from last year. So make sure that they're paying attention to the 15 that got carried over to continue add-on payments for fiscal year 23. Now in the last few minutes here, I want to talk just a few highlights from the IPPS final rule, kind of a bonus, which I wasn't really planning to talk about, but I thought I'd give you a little bit of this because I think there's a few things that are somewhat important here. They're always making changes, in the data as they find errors and stuff where the grouper logic is not right. But I wanted to point out these two new technology codes that have been out there. They're both new procedure codes, and they are they will group to those pre-MDC DRGs. They're CAR T cell and other immunotherapies. You saw one of those on that slide that had the huge payment as well. That was a CAR T cell immunotherapy, but be aware of those and what the codes are that go with those. What they did here was assigned ARDS from the 204 DRG to 189, and you can see the difference in relative weight. That's definitely a good move. You don't always see ARDS as a principal diagnosis, but nevertheless, when you do, you want to get a better, payment for that because that's a very serious condition. Also, they found in the grouper logic that this supplement mitral valve code had been grouping the wrong way, and they have fixed the grouper logic and got it grouping to the correct DRG. So just wanted to point that out. These post-procedural heart failure codes, they discovered had not been included in the appropriate DRGs. So they have regrouped the logic for those to make sure that they get coded in the right grouper for these two DRGs. This extirpation code also was revised from a non-OR to an OR procedure, and it was not grouping correctly either, so they have fixed that. So they basically have made sure that if they do common bile duct exploration along with a lap chole and a gallstone removal, that it will get recognized as having been done and it will group to the right place going forward. A couple of revisions to the OR and the non-OR list. There's a whole lot of documentation in the final rule about how CMS evaluates procedures to determine whether they should be an OR procedure or not. And it used to be the definition was whether it would be performed in an operating room. Well, in today's world of technology, that is no longer a good definition of an OR procedure. There's so many other things to consider to determine what should be technically an OR procedure versus a non-OR procedure. So be looking for changes to these as we go forward, because they have a multi-year project they've launched to try to review the process and to determine what is the best way to determine what should be gripping as an OR procedure and what should not going forward. And then I wanted to talk about the new technology add-on payments. I've already been talking about the new ones for this fiscal year, but unless you are unaware of this, in the proposed rule that came out, they were proposing to quit using the X new technology codes and use the national drug codes instead to identify all those different drugs and substances that are coming out. The C&M Coordination and Maintenance Committee came out and said PCS was not intended to represent unique drugs and therapeutic agents, and it's not an appropriate code set for this purpose, which is what led them to want to propose the NDC codes. Well, they had a lot of feedback about that. And so then they were proposing a transition for fiscal year 23 where both NDC codes and PCS codes would be used together for a year, and then they would move solely to the NDC codes for fiscal year 2024. A lot of issues about that as well, because some people pointed out that the pharmacy and billing systems do not currently require use of NDCs for billing on Medicare claims, and they would have to manually process all of that stuff, and a big old mess. So basically, they have decided to reassess all of this and, address it again in future rulemaking to determine what is the best way to handle these new technology add-on payments for drugs. So more later on that, you can stay tuned. And I believe I'm at the end of the thing, and so I'm going to turn it back over to you, Sharon, to talk to them about the CEU credits.
Great. Thank you so much, Joy, for a fantastic webinar, as always. So for those people that are on this live webinar right now, you will receive an email from TrueCode tomorrow morning. That email will contain a link to the handout, a link to this webinar recording. Feel free to share it. It will also contain a link to an evaluation. And when you click on that evaluation, it's super simple, just a couple questions. Once you complete that, you'll be able to download your CEU certificate. So that's how you'll get your CEUs through the email. The URL that I have up on the screen right now, you can also go, don't click on it yet because it's not live until the webinar ends, but this is another URL that takes you to that evaluation, and you'll be able to complete your evaluation and download your CEU. So this is the way that folks that watch this on demand will be able to access their CEU certificate. But again, this is not live, so please just hold off a few minutes until we get this live. I think that covers it. Karen, anything you wanted to add?
No, I think that's great. Thank you so much, Joy. That was so much information. We do have several questions. We will be sending those out to Joy, and she will respond to those, and we will get those out to you as soon as we can.
Excellent. Yep, I'll send those out via email to everybody that attended so that you have them.
And thanks everyone for letting me share with you today. I appreciate it.
Thanks, Joy. We'll have a fabulous rest of the day, everyone. We appreciate your time, and we will see you on another webinar soon. Take care, everyone. Bye-bye.